Hello everyone. Welcome to the Docsaab's diary. And today I am going to teach you about atropine injection, a cornerstone medication in emergency medicine, anesthesiology, and toxicology. Today we will discuss its pharmacological properties, explore the mechanism by which it applies its effects, review its diverse and critical clinical applications, and address the essential consideration for its safe and efficacious administration in clinical practice. So, what is atropine injection? Atropine injection is a meticulously prepared sterile medicinal solution with atropine sulfate as its active pharmaceutical ingredient. It's a naturally occurring alkaloid derived primarily from plants of the Solanaceae family, such as Atropa belladonna, commonly known as deadly nightshade, or it can be synthetically produced. From a pharmacological standpoint, atropine is classified broadly as an anticholinergic agent, meaning it blocks the actions of acetylcholine. More specifically, it's an anti-muscarinic agent, targeting muscarinic acetylcholine receptors. Chemically, atropine is a tropine alkaloid with a molecular formula C17H23NO3. For a clinical use, it's typically formulated as atropine sulfate because this salt form significantly enhances its solubility in water, making it suitable for intravenous, intramuscular, or subcutaneous injection, and ensuring rapid systemic absorption. Now, let's talk about its mechanism of action. Atropine's therapeutic efficacy rises from its role as a non-selective competitive antagonist of all five subtypes of muscarinic acetylcholine receptors like M1, M2, M3, M4, and M5. This competitive binding means that atropine occupies the receptor sites without activating them, thereby preventing the natural neurotransmitter acetylcholine from binding and exerting its physiological effects. This blockade effectively suppresses the rest and digest function normally mediated by the parasympathetic nervous system. Going deeper into its key effects, at the heart, atropine selectively blocks M2 receptors located on the SA and AV nodes. This action removes the vagal nerve's inhibitory brake on the heart, leading to an increased firing rate of the SA node and enhanced conduction through the AV node, resulting in an elevated heart rate. In a secretory glands and smooth muscles, atropine blocks M3 receptors, significantly reducing saliva, bronchial secretions, and sweat production, and promoting relaxation of smooth muscles in the bronchi and gastrointestinal tract. Furthermore, atropine's lipophilic nature allows it to cross the blood-brain barrier, exerting central nervous system effects by blocking muscarinic receptors in the brain, especially at higher doses, leading to potential agitation or delirium. Let's unpack its clinical uses. Atropine is a critical component in various acute care scenarios. Its most vital application is its first line treatment for symptomatic bradycardia, an abnormally slow heart rate, typically below 60 beats per minute, which is causing clinical symptoms such as hypotension, syncope, or altered mental status. By blocking vagal input to the heart, atropine effectively increases heart rate and improves AV conduction, often restoring hemodynamic stability. In this setting, the typical adult dose is 1 milligram intravenously, which can be repeated as necessary. Secondly, atropine is widely utilized as a pre-anesthetic medication administered prior to surgical procedure. Its potent anti-secretory effect significantly reduces salivary and bronchial secretions, which is crucial for preventing aspiration during intubation and maintaining a clear airway. Beyond secretion control, it also prevents reflex bradycardia and other dysarrhythmias that can be triggered by surgical manipulation or certain anesthetic agents, thereby stabilizing cardiac rhythm throughout the procedure. Beyond its acute cardiac and perioperative roles, Atropine serve as a life-saving antidote for a specific toxic exposures. It's the primary pharmacological treatment for poisoning caused by organophosphate or carbamate insecticides, as well as chemical nerve agents like sarin or VX. These toxins inhibit acetylcholinesterase, leading to dangerous accumulation of acetylcholine and severe cholinergic crisis. Atropine directly antagonizes the muscarinic effects of this acetylcholine axis, elevating symptoms such as bronchospasm, excessive secretions, bradycardia, and gastrointestinal hypermotility. It's also effective for poisoning from certain muscarinic mushrooms. In addition to these approved uses, atropine has important off-label applications. Like in ophthalmology, it commonly used in eye drop formulation to induce mydriasis or pupil dilation, which is essential for comprehensive retinal examination. It's also employed in pediatric ophthalmology to treat amblyopia or lazy eye by penalizing the stronger eye, and increasingly in very low concentration to slow the progression of myopia or nearsightedness in children. Less commonly now, it has been combined with other agents to reduce gastrointestinal motility for conditions like irritable bowel syndrome or diarrhea. The administration of atropine must be precise and tailored to the specific clinical indication and patient characteristics. The intravenous route is the preferred method for acute emergency scenarios due to its rapid onset of action, typically within 30 seconds to a minute, ensuring immediate therapeutic effect. However, it can also be administered intramuscularly, subcutaneously, or in emergency condition when IV access is not immediately available via an endotracheal tube directly into the lungs. Doses vary significantly. For adult symptomatic bradycardia, the standard dose is 1 milligram administered as an IV push, which can be repeated every 3 to 5 minutes up to a total cumulative dose of 3 milligrams. It's crucial to note that doses less than zero point 0.5 milligrams in adults may paradoxically causes a further slowing of the heart rate. For organophosphate poisoning, significantly higher and aggressively titrated doses are required. Initial doses typically range from 2 to 5 milligrams intravenously, and these doses are double every 3 to 5 minutes until the primary endpoints are achieved, which includes clear lung fields, drying of secretions, and resolution of bronchospasm. The goal here is respiratory stabilization, not necessarily normalization of heart rate, as tachycardia is an expected side effect of these large doses. Pediatric dosing requires a strict adherence to weight-based guidelines, typically 0.02 milligrams per kg, with careful attention to minimum dose consideration in a very small infants to avoid a overdose. As with any potent medication, atropine carries a distinct profile of adverse effects, which are direct extension of its anticholinergic properties. Common side effects, generally dose dependent, include a profound dry mouth due to reduced salivary gland secretion, blurred vision, and photophobia resulting from pupillary dilation and paralysis of accommodation. Tachycardia from increased cardiac activity, facial flushing often described as atropine blush, and gastrointestinal effects like constipation due to decreased gut motility. More serious adverse effects can manifest particularly with higher doses or in susceptible individuals. These include potentially dangerous cardiac arrhythmias such as ventricular tachycardia and fibrillation, which can be life threatening. Due to its ability to cross the blood brain barrier, atropine can induce significant central nervous system effects ranging from restlessness, agitation, and confusion to profound delirium, hallucination, and even coma, especially in the elderly. A critical serious adverse effect is hyperthermia caused by the suppression of sweating or anhydrosis, which impairs the body's natural cooling mechanisms, leading to a dangerous rise in core body temperature, particularly in warm environments. The classic mnemonic for the toxidrome of atropine overdose encapsulates these effects vividly. Hot as hair, blind as bat, dry as bone, red as beet, and mad as hatter, summarizing the fever, dilated pupils, anhidrosis, flushing, and altered mental status. Now let's talk about its contraindications and monitoring. To ensure patient safety, it's important to recognize the absolute and relative contraindication for atropine use. It is strictly contraindicated in patients with known hypersensitivity to the drug. Conditions like angle closure glaucoma are contraindication because atropine-induced mydriasis can precipitate an acute glaucoma attack by further closing the iridocorneal angle and impeding the aqueous humor outflow. Similarly, in patients with mechanical obstruction of the gastrointestinal or genitourinary tracts, such as pyloric stenosis or benign prostatic hyperplasia, atropine can exacerbate the obstruction, potentially leading to complete urinary retention or paralytic ileus. Due to its profound effects, meticulous monitoring is essential for patients receiving atropine. This includes continuous electrocardiographic monitoring to track heart rate and rhythm, vigilant blood pressure assessment, and close observation of respiratory status, especially in poisoning cases where the primary goal is to drive pulmonary secretions. Mental status must be continuously evaluated, particularly in elderly patients who are more susceptible to CNS side effects. Finally, core body temperature should be monitored, especially in febrile patient or hot environment, given the risk of atropine-induced hyperthermia. We must also consider special patient population who demonstrate altered responses to atropine. Geriatric patients, for instance, are significantly more sensitive to the anticholinergic effects of atropine, particularly its central nervous system side effects such as confusion, agitation, and memory impairment. They also face an increased risk of urinary retention and constipation. Therefore, dose selection in the elderly should always be cautious, starting at the lower end of the therapeutic range. Pediatric patients exhibit a prolonged elimination of half-life for atropine compared to adults, meaning the drug remains in their system for a longer duration. This necessitates strict adherence to weight-based dosing and careful consideration of minimum dose recommendation, especially in neonates and very small infants to prevent accidental overdose. A unique and critical consideration involves patients who have undergone cardiac transplantation. In these individuals, atropine can paradoxically cause a severe and sustained slowing of the heart rate due to denervation of the transplanted heart. Its use in this population should be approached with extreme caution or avoided altogether. In conclusion, atropine stands as a truly versatile and potent medication indispensable across a spectrum of medical emergencies and clinical procedures. However, its powerful pharmacological effects demand meticulous administration, individualized dosing, and diligent monitoring to maximize its therapeutic benefits while mitigating its inherent risks. Thank you so much, guys, for the watching, and please like, share, and subscribe to the Docsaab's Diary.